Hi Brendan, my name is Ali. I'm one of the emergency consultants. Look, thanks for asking me to talk you through hyponatremia. Brendan, may I ask what level you are? Intern, okay. And have you dealt with any case of hyponatremia before? No, okay, no, that's fine. Okay, so we'll talk about assessment of hyponatremia, and also we talk about some how to investigate for causes of hyponatremia. That sounds reasonable. All right, let's have a look at her blood test. So she's got a sodium of 117, so that's moderate hyponatremia. Looking at the kidney function, she's got a normal kidney function, so that's indicate that the renal pathology is not the cause of her hyponatremia. And also she's got a normal glucose, so she's not having hypertonic hyponatremia. Her potassium is normal, so renal or endocrine causes are likely in her condition, and she doesn't appear to be hypovolemic or hypervolemic. So most likely in Mrs. Costantini's condition is going to be euvolemic hyponatremia. In terms of how to approach is usually we're looking for the cause, and according to the volume status of the patient. The patient with can divide it to hypervolemic hyponatremia, euvolemic hyponatremia, and hypovolemic hyponatremia. Hypervolemic, we're talking about causes like CCF, nephrotic syndrome, liver failure, liver cirrhosis, and in that case the urinary sodium will be less than 20. If the urinary sodium more than 20, causes like renal failure and diuretics and cerebral salt wasting. Euvolemic causes, the most common is SIADH. And there's certain criteria for SIADH. They have to be euvolemic, they have to have a urine sodium more than 100, they need to have a normal kidney function, liver function, and thyroid function. They're not supposed to be on any drugs dealing with water excretion like diuretics. The criteria for, so this is the criteria for the diagnosis. What could have caused SIADH? Different, most common is the drugs, SSRI, phenothiazine, ecstasy, and carbimazole, and TCA. Infection like pneumonia, lung problems, heart failure, COPD, could be malignancy like lung or cerebral malignancy, intracerebral pathology like stroke or a tumor. Other causes of euvolemic hyponatremia is the polygenic polydipsia, psychogenic polydipsia, and also water intoxication, some endocrinal causes like hypoadrenalism and hypothyroidism. In terms of the hypovolemic, it's most likely from a GI loss like vomiting and diarrhea, or burn sometime, third space loss, or in some occasions could be intestinal obstruction. In these cases, you would look at the urine sodium, and it should be less than 20. If the urine sodium more than 20, the other causes could be renal failure, hypothyroidism, adrenal insufficiency, and also renal salt wasting as well. So this is mainly the general causes. Put things in context, it's most likely in Mrs. Costantini's case, as we said before, she's not hypovolemic or hypovolemic. Most likely is going to be euvolemic. Investigation I would look for is chest X-ray, a blood test, checking the blood sugar to start with, because sometimes hyperglycemia can cause pseudo-hyponatremia or low hyponatremia, and there's a formula how to correct the urinary sodium in case of hyperglycemia. Osmolarity, as we mentioned before, just to differentiate between SIADH and other causes of hyponatremia. We do urinary sodium, same scenario, we need to differentiate between different causes of hyponatremia according to urinary sodium as well. Check cortisol level, thyroid, because both can cause hyponatremia, and also looking for sepsis, we do LFB as well. In terms of imaging, I'll do a chest x-ray, looking for any signs of pneumonia, heart failure, or lung malignancy. If there's any suspicion of lung malignancy, I'll proceed to do a CT scan of the chest to delineate the issue further. In terms of other imaging, I will organize a CT brain, making sure the patient has got no malignancy that could have caused her hyponatremia. Are you following Brendan so far? Okay. Any question? All right. So let's talk about, let's summarize what we've talked about to Brendan. So we've talked about the potential causes of hyponatremia. In that instance, most likely is going to be related to euvolemic hyponatremia, because there's no evidence of hyper or hypovolemia. Given that she's a heavy smoker, I'm suspecting that she may have malignancy, most likely lung, but also looking for another pathology, any drugs, or has been changing the medication recently that could have caused that. In terms of also, we keep the other differential for hypovolemic causes and hypervolemic causes, and then we've decided to differentiate between different causes according to the urine level, urine sodium concentration. And investigation, we start with checking osmolality, urinary sodium, urine osmolality. Would like to check the thyroid, the cortisol level, in terms, and also making sure the glucose is normal, making sure they've got normal protein and lipid, because sometimes we can have a pseudo-hyponatremia or factitious hyponatremia. Also making sure that blood sugar is normal. Also, we have to check for imaging like X-ray and CT brain. Any questions, then please don't hesitate to ask. And as I said before, I would like to organize, if you would like, we can have a case presentation to consolidate your knowledge about hyponatremia. Thanks, Brendan.